Yeah, first of all, Dr. Yahagi,
Yep.
yeah, you presented one of the slides, 0.16% of distant metastasis. Even it is mainly non-curative resection, but 16 patients among 1,000 is not small. So what is the recommendation for the inclusion? Not from the inclusion table, but from the clinical settings, because I have some experience that the procedures in United States. I'm not sure how they include the patient. Okay, so even early gastric cancer, we are very cautious to include the ESD case, right? So how's your recommendation for the inclusion in usual clinical setting?
Yeah. It's very important question because unlike United States, we usually check the referred patient by ourselves before conducting actual ESD procedure. Where is the location, how is the maneuverability, and of course, how is the invasion depth and how large it is. And considering the size and the depth of the lesion, we carefully select the actual candidate for doing ESD. Otherwise, we cannot achieve good clinical outcome. I believe that preoperative checkup is mandatory for everyone of us when we conduct ESD.
Okay.
Thank you all for your excellent presentations. We're seeing worldwide, and particularly in the United States, early onset of many cancers and association with obesity. Can you comment on that? Is that a factor in gastric cancer? Are we seeing a shift to earlier individuals, and if so, what are the associations and what are the implications for age at starting of screening? Because I've seen under screening studies anywhere from 40 to 50 years to start. So,
yeah, I can start off. So it's a great question, and it certainly is a trend that we are observing is an earlier age of onset. So even though we know that the highest incidence really is in the older age groups, that we are seeing a trend there. It's challenging because still from an absolute number, it's still a small number of cases, but really kind of getting to that point of looking at trends. And so specifically with your question related to obesity, that the association between obesity and gastric cancer is strongest for cardiac gastric cancer, since those follow along the same risk factor profile of esophageal cancer, gastro, and the GE junction. But we are seeing a small association with non-cardiac gastric cancers as well, including independent of H. pylori. So we're not certain of the causes. Same thing with colorectal cancer. We're clearly seeing a spike there. And so I think really understanding that shift has been a recent shift, and really looking to environmental factors and the interaction with genetic predisposition. So it's a great question.
Yeah, and just to add, Costanza Camargo, I think she spent a lot of time with us, as well as Julie Parsenet is also going to speak. We were part of a CDC Arctic response team, and it turns out that there is an outbreak among Alaskan natives with diffuse type gastric cancer, and the etiology is kind of confusing. So there's a lot of concern, and getting back to the broader motif. Minority groups are disproportionately affected in the early onset as well. So this is a concern. But next question. I mean, I think Costanza can also add to this later. I don't think you're covering this.
Hi. It's a question for Dr. Park about the randomized trials. Really looking forward to seeing your results. I'm wondering if in the treatment arm, do you have eradication verified? In that group, I suppose that if it's intention to treat, it really doesn't matter that much, but it would be really interesting to know. So just curious about that.
Thank you very much. I'm actually glad that I'm here sitting together with Dr. Choi, whom we are actually coordinating the study together, but he's the main PI. But to answer your question, and then Dr. Choi can complement it later. But when we started the study, we actually verified the eradication success in a subgroup of participants, and then that showed actually higher than 90% of eradication rate. So we are actually quite confident, and then that eradication worked out well. But this study is also important because we are showing actually we will be providing evidence how that would have worked in the general population. So we will be able to provide more evidence on the eradication success, participation rate, and everything in the upcoming publication. Maybe Dr. Choi may complement.
Actually, in our previous study, in family history study, we checked the compliance and the eradication status every person who participate. But this general population study who participate National Cancer Screening Program, we cannot check the eradication status because of lower compliance to check the eradication status. So we changed the medication to bismuth quadruple therapy, and it will be we can achieve more than 90% eradication rate. And actually, we only check the only subgroup of the eradication status.
This question is also for Dr. Choi about the Korean National Screening Program. And just to follow up the question about early onset, I was curious how you guys are thinking about bundling upper endoscopy with colonoscopy for cancer prevention, and what the implications are for effectiveness of screening for both cancer types. And as you are doing earlier screening for gastric cancer in Korea at age 40, is there an opportunity to bundle colonoscopy with upper endoscopy in that younger age group as the incidence of, colorectal cancer is rising so markedly in Korea in the younger population?
In our colorectal cancer screening is currently the fecal FIT test, not colonoscopy is the primary screening method. So we do not recommend upper endoscopy and colonoscopy at the same time. But each program was separated, and the government, the National Health Insurance, sent the invitation letter separately. So,
can I just add to Andy's question? I know we're almost out of time, but I was just part of the reason we're here is try to reduce the burden of gastric cancer, both in the world and the U.S. And I'm thinking in the U.S. context, when we think of the success in East Asia, like Japan and Korea, we don't have, fortunately, we don't have the incidence and burden here in the U.S. that is in East Asia and parts of South America, for example. But do you think it'll work in the U.S.? And I'm thinking of a couple of things, like if we do a targeted approach, like kind of where we're going to, and there's policy and everything lines up, do you think it'll work? And I'm thinking of everything from adherence and potential biology. Do you think it'll work, will be impactful in terms of actually reducing cancer mortality?
So I can
Yeah,
comment on that, especially in the United States.
Yeah.
So in theory, yes, but the big elephant in the room is that our quality of endoscopy in the United States, that's going to be our Achilles heel, because we know that most general, endoscopists, that these lesions, as we saw so nicely, are subtle. Those are going to be missed if we don't teach on kind of a broader thing. So we really do need to actually start with training efforts and with lesion detection. So I think that's where we're going to have trouble.
Yeah.
Time for one more here.
Yeah. Actually, I think that's a real thought to chew on over the break. But
Hey, can I follow up on that? In Korea and Japan, as the programs become more effective and the ages for screening might go up, and the population might become perhaps more like here, because colon cancer is becoming a bigger deal in Asia. Do you think that the target for Asian screening and surveillance, like right now you're screening for cancer, but as there are fewer cancers, will you start looking for pre-malignant lesions? In the past, everyone has intestinal metaplasia and atrophy, and you look for cancer. Here, we don't have everyone with cancer and some people with intestinal metaplasia and atrophy. Will the target in Asia change, or would always still be screening for cancer? Does that make sense?
You ought to try that, Dr. Che.
Actually, same as the cancer prevention, cancer screening test. With preneoplastic lesions, because it is a continuum of the lesion. So, but the target for the neoplastic lesion is non-specific. So we don't know how many years for the becoming gastric cancer. So it is a little bit tricky. So I'm sure the target should be carcinoma. And regarding the age, it's very difficult. So the early onset gastric cancer is usually 20s and 30s, but the incidence is very low. So it cannot be included in the screening program. So it should be individualized, depending on the family history and the subject, the habit, okay, and the H. pylori status, and other factors. But for the mass screening test, should be targeted the certain more than certain range of incidence. So there is thinking about the United States should be narrowed down to the subject having atrophy and metaplasia, regardless of H. pylori status. Okay? And then second thing is the skill and the interpretation of endoscopy. I think it is not sufficient for the upper endoscopy compared to the low endoscopy. So the training and the education system should be go parallel with the political aspect.
Yeah, and just one comment on top of that before we close the session was I was really interested in Dr. Che's presentation on the number of high-grade dysplasia or dysplastic lesions that are being resected, and you can parallel that to colonoscopy and resection of adenomas, right? And clearly those prevent cancers as opposed to the treatment of cancer. And I think that we're after both of them. I think we're both after both the pre-malignant, especially the advanced pre-malignant lesions that will turn into a cancer to prevent cancer, and then ideally early gastric cancer that can still be curatively resected, as Professor Yahagi demonstrated. And I think that those should both be equal goals in terms of our endoscopic evaluation. And I 100% agree with Shailja. And fortunately, she sets up future talks really well in the summit, talking about the quality of endoscopy, and I think we're really making some great progress in that. Ask the moderators to close this session, and then we'll go to a break.
Okay, thank you so much for the participation of lectures and the Q&A session. Thank you.